All right, good morning, good afternoon to everyone on the program today. I want to thank you for joining us today for the Institute for Safe Medication Practices webinar entitled Important Actions Community Pharmacies Need to Take Now to Reduce Potential Harmful Dispensing Errors. My name is Matt Grissinger. I am the Director of Error Reporting Programs, and I will give part of the presentation and also moderate today's program. Some housekeeping items. First off, I need to thank Novartis, specifically the Name Creation and Regulatory Strategy Department of Novartis, for supporting this activity today. Second, this program will be recorded and will be available soon on the ISMP website. All attendees are in listen-only mode throughout the presentation. And if you want to ask a question, at the bottom of the screen, when you move your mouse at the bottom, you'll see a Q&A icon on the black bar. That if you click on that, that'll give you a chance to throw a question in there that we'll be able to get to sometime before the program is done today. So just type in your question, hit submit. So Jordan, let's go to the next slide, please. So just here are the objectives for today. We're going to define the term high-alert medications as it relates to community ambulatory pharmacy practice. Recall some commonly used medications that are considered high alert in that setting, and discuss some of the types of events and contributing factors associated with errors involving vaccines, including those involving COVID-19 vaccines and flu vaccines, and also discuss the adoption of proven prevention strategies designed to prevent or identify medication and vaccine errors in these settings. So let me, before we start the program, let me go over the speakers for today. First, again, I'm Matt Grissinger. I'm the Director of Error Reporting Programs and started at ISMP in 2000 as a fellow at ISMP. I'll be followed by Mike Cohen, who is the president and founder of ISMP. Mike is the co-editor of the ISMP Medication Safety Web publications that reach millions of healthcare professionals in the US, regulatory authorities, and professionals in over 30 foreign countries. Mike also is the chairperson of the International Medication Safety Network, which is an international group of experts leading medication safety experts in more than 25 countries. He's also served terms on US FDA Drug Safety and Risk Management Advisory Committee, as well as the Non-Prescription Drug Advisory Committee. He's a current member of the USP Expert Committee on Labeling and Nomenclature. And wrapping up the presentation today will be Mike Gaunt. Mike Gaunt is a medication safety analyst and editor at the Institute for Safe Medication Practices, where he joined here in 2004. Mike co-coordinates our reporting programs, the medication error reporting programs, as well as the vaccine error reporting programs that we'll talk about today. In this role, he also does a lot of work with the FDA to advocate for package labeling nomenclature changes, and also has participated in many risk assessments, especially the ambulatory care areas, community pharmacies, to assess those areas for risk and identify opportunities for improvement. And lastly, Mike is also the editor of our monthly ISMP Medication Safety Alert for community and ambulatory cares. So on that note, Jordan, let's go to the next slide and start the presentation. So I'm going to talk for about 20 minutes today in my section. So we're going to talk about high-alert medications in this setting. So the first thing we have to do is define the term high-alert medication, right? So the key thing with high-alert medications is it's not, when you look at all the medications available in the world, it's not, it's only a small number of those medications that have a high risk of causing injury. So the one important thing about this is it's not medications commonly involved in errors, but these are medications that when they are involved in an error, the chance of harm is a lot higher than other medications. So that's a key part of this definition, is not the quantity of reports, but more so the severity of the harm that could happen with these medications. So Jordan, let's go to the next slide, please. And this is just a list of a high-alert medication that is exclusively from the Community Pharmacy Ambulatory Care newsletter list. So you'll see to the right examples of antithrombotics, chemotherapy, insulins, and so on down the list. So we're going to talk about today the antithrombotics. We're going to talk about specific chemotherapy like methotrexate. We're going to talk about the insulins today and opioids, as well as you see the methotrexate left-hand column. So keep in mind the importance of this slide is, and we'll go over the premise of the list at the end of my part of this presentation, is that think about, say, an overdose happens with an insulin or an opioid or anticoagulant. And let's just say it's a tenfold overdose. And the chance of harm from these medications is significantly higher compared to other medications. So Jordan, let's go to the next slide. As a background about high-risk medications, I have 2 slides to review. First is something that came from our sister organization in Canada, ISMP Canada, and they published a report. You see the citation at the bottom of the screen, medications most frequently reported in harm incidents over the past 5 years, and it came out in 2020. And you look at the medications on this list, and what do you know? We have an opioid, chemotherapy, an opioid, and insulin product on this list. And when they did this, I think they did it in 2013, and the list was more or less the same, predominantly high-risk medications. So again, these are things that are causing severe harm or death in patients' homes in Canada. Next slide, please, Jordan. So let's look at this thing. Now, this specific study is from 2011, from Dr. Dan Budnitz and other people from AHRQ, if I'm correct. And he wrote about medications whose average drug events led to someone having to go to an emergency department. And so if I'm correct, he just came out with another updated version of this article this year or last year. He has at least 3 similar articles, some looking at older Americans, some looking at all Americans. And if you look on the right-hand side, and Jordan, I think you probably do like maybe 5 advances, Jordan. You see arrows coming in here. And we're going to point out the list here with warfarin, insulins, antiplatelets, oral hypoglycemic agents, opioid analgesics, and I think that's the last one, Jordan. So stop right there. So all the arrows we're talking about today. Now, one thing to clarify about this article. So it's saying these people went to an emergency department because they had an adverse drug event from these medications. It is not saying they're medication errors. But that being said, what's community pharmacy and ambulatory care's role in this? So these are medications that clearly had to be filled in the outpatient setting, and something went wrong at home to the point where they had to go to the emergency department to take care of the problem. So look at the list. Again, just the warfarin oral antiplatelets alone represent a pretty high number there, as well as the insulin. So, and you see the percents, that's a proportion that result in hospitalization in the right-hand column. So look at the right-hand column, that's essentially saying almost half of people came to the ED with a warfarin problem were admitted. Over half of people with a problem with oral hypoglycemic agents were admitted. So that's a pretty significant number. So what is our role in this in the outpatient setting? So Jordan, let's go to the next slide, please. So first section we're going to talk about for about 5 minutes is anticoag. So we're specifically talking about warfarin, potentially heparin in the setting, probably more enoxaparin issues in the setting, but also all the newer DOACs as well. So next slide, please. So a couple of issues with warfarin. Now, these issues are problems with patients, consumers, but also kind of originate at the prescribing end, and is also what's the role of the pharmacy in all of this from both ends, catching prescriber issues, but also teaching patients how to correctly use their medications, right? So, for example, picture the dosing errors with warfarin, especially when we have prescribers get a little carried away with the Monday, Wednesday, Friday dosing, the Tuesday, Thursday, Saturday, Sunday dosing that have to be different. So it's this alternate dosing, it's a different dose every day. You have issues where in a pharmacy may not be involved, whereas a change in directions done over the phone. So how does the outpatient pharmacy even know what the patient really is on when doses get adjusted mid-month between refills? And are those changes caught or changed in the profile of the patient in the pharmacy, or is it just done verbally in the patient's home? And what's pharmacy's role in that situation? And also have issues here with multiple warfarin products. There's still some brand names like Jantoven out there. And this issue will rear its ugly head again later in this presentation. Think about patients who are being, say, in acute care setting, discharged to home, where they were on a Jantoven going in, and then somehow they end up on a different warfarin coming home, and they end up being on both warfarin products. And right, again, both fill in the same pharmacy. Does a pharmacy know that they should be on both at the same time, that one's replacing the other? So what's pharmacy's role with the multiple warfarin orders and types of warfarin in a patient's profile? Next slide, please. And I call this title Anticoagulant Problems, even though it kind of starts with the warfarin problem, is what is pharmacy's role with anticoagulation? Now, I'm not speaking about anticoagulation clinics, which are great places where pharmacists are involved with managing anticoagulant therapy in that setting. I'm talking about your regular community pharmacists. So remember, pharmacists in the outpatient setting don't get labs unless they're maybe attached to a healthcare facility. So pharmacists are filling warfarin with no INRs, not knowing how good, bad, ugly the dosing is going. And these pharmacists probably won't know the variety of stuff that they're on that may interact with warfarin. So the drugs you think would be easy, assuming the patient gets everything filled at that one pharmacy or that one chain, so we know the big picture of everything that they're on, and knowing there's a lot of interactions with warfarin, right? Because it's been around for so long, we know about them. How about the herbal medications? Are there any herbals you shouldn't take with warfarin? And how does that outpatient pharmacist know that? How about the food interactions and food with vitamin K in it? Is that discussion happening at the pharmacy? So when someone comes in with a prescription for warfarin, what does that counseling look like, if that counseling is happening at all? Or are we just simply filling it? And lastly, going back to the topic of concomitant use of anticoagulants, same topic we discussed before, the problem being now, it could be a DOAC in a warfarin or multiple DOACs. We've seen this problem definitely in acute care facilities, and the concern being here is, for me, is the transitions of care going in and out of facilities and the reconciliation process. So who is finalizing that final medication list? Who is kind of reviewing to say, hey, why are you on both of these DOACs for, as an example for that? And I see a comment from Michelle, it's hard for retail pharmacists to get access to lab values. And Michelle, absolutely. It depends on the setting and the time, right? And Michelle, the other part is you have to go look for the labs versus you being told what the labs are to be more involved in that, Michelle. So that's an excellent point you make there. It's access is not simple. And so what can we do to move forward with that? Because Michelle brought up a good point in the chat box there. Next slide, please. And then DOAC issues. And again, we've seen, at least in the inpatient setting, many issues with DOACs that are also happening in the outpatient setting. Part of the issue is bridging when starting a DOAC. So say we're going from one anticoag to a DOAC, or a DOAC to another anticoag. What's that bridging look like? And what is do we have a role in overseeing this? Or are we only filling what's in the middle of this three-step process? Are we only seeing the end of the process? Again, come back to the concomitant use of warfarin with that. Again, we definitely see issues with, at times, multiple DOACs as well, where one started and the second one started thinking they should prescribe two of them. So again, a lot of these I'm mentioning on here, originate the prescriber end, right? But that being said, what's our role in potentially catching these multiple therapeutic duplications? And we've seen issues with confusion between starting and maintenance dosing and the dose packs that they have. So dose packs are great to help patients kind of do the right thing in the first month and the second month. But we've had problems where we have reports of people issuing refills on a starter pack when a starter pack is only for 1 month. We've had people get starter packs that were actually a teaching starter pack with no pills in it get dispensed in pharmacies, let alone, and also at times when, in theory, we should have one starter pack filled the first month, then the second pack, the second one, because there's a different dose. But instead, people get both filled at the same time, the first and second month. So people start taking both at the same time. And again, there's probably no conversations saying, okay, this first pack of 5 milligrams a day, you're doing that the first month. Then when that's finished, you're done with that, then you're starting with the next starter pack. So a lot of issues, great products with the packs to help people know what to take when, but we also need to understand what can go wrong at the patient's end as well. Next slide, please. Moving on to insulin, so we'll go to the next slide here. And so the next slide, we'll talk about problems in the pharmacy. So we're, just think in your refrigerator what that looks like, right? And how has the insulin market exploded for us in the outpatient setting in the past 10 years? What we had 10 years ago and now is probably doubled. So just So it's a combination of buying insulin from one manufacturer that all looks similar, or another manufacturer that all look similar. On top of the storage conditions, small refrigerators, we don't have bins to separate them, no labels to separate them. So that has caused problems, and you end up just simply grabbing the wrong thing, sometimes blaming the package and labeling when really it's just as much the storage condition or the lack of barcode scanning as well. But also patient information. Again, unfortunately, back to Michelle's point, well, you're not getting blood glucose levels. So what is a pharmacy's role in helping a patient control the blood sugars? Do they have access, or can they get involved in knowing blood glucose levels or A1C levels to help patients so they can kind of do some long-term monitoring throughout? Keeping in mind that other medications impact insulin use, as well as what time they have their meals and the timing of the prandial insulin with the meals as well. Often, again, we're just filling insulins with labels, but can we get more involved clinically to manage a patient as well? Next slide, please. But also, we see a lot of errors with patient use at home with insulins. From the first one, you'll see at the bottom, by the way, I cited all the newsletter articles we've written about insulins for each slide here. So the first one, when you dispense an insulin, do you know what the person's vision's like? Do you know the person may be hard, may not be able to see well? And so now they're judging their insulin types and pens by feel and touch, except when both pens feel the same. And then patients are giving themselves the wrong insulin because they can't see the difference because there's visual acuity issues. So how can we help them, teach them about applying some sort of tactile thing to that pen to differentiate one thing or separate the storage? Problems with changing concentrations of insulin for patients from a one pen device from 100 unit to a 300 unit per ml. You see a citation for the Traceba down below, where we've had patients who couldn't see, so they would count the clicks of the pen. So 7 units of 7 clicks. Then they go to the next concentration, and they're still going by the 7 clicks, but now that's 14 units, not 7 units. So how are we getting involved with counseling patients to have them demonstrate to us, show me how you're going to use this, show me how where you're going to dial it back to, show me how you're going to apply the needles. And also we've had issues with sharing pens, predominantly inpatient setting, but something we need to warn patients in the outpatient settings, that's not cool to be sharing pens with other people. Next slide, please. One issue that came up that you see at the bottom of the citation, we also had a national alert based on this problem. We had a person die, and many other reports because of the issue on the screen here, where on the left-hand side, what you'll see is a traditional safety pen needle predominantly used in the hospital setting. So you'll see that there is a outer cover you take off, and then below the needle shield, the needle, when you press the injector, the needle comes out from behind the plastic shield, injects the person, gets retracted back into the shield. And the patient sees that and thinks, okay, so when they go home though, what are they getting at home? And so when you're filling the pen needles in that pharmacy, do you know what they had beforehand as well? And so you'll see in this situation here, so you see the outer cover for the standard pen needle on the right-hand side, but that requires also removing a needle cover. So you're removing 2 things, not one, like the left-hand side. So yeah, patients have taken the outer cover off, kept the needle cover on, and tried to inject themselves with that pen, and they're getting no insulin. And yeah, people have died from severe hyperglycemia because over a time period, they were never getting their insulin, and yet even admitting to wiping off the excess insulin on their skin at the same time. All right, so next slide, please. Yeah, again, I see Michelle, thank you for the comment in the chat again, because she's seen patients reuse pen needles to save money as well, which is not good to say the least as well. So thanks, Michelle, for that comment. So one last thing before we move on is, ISMP on our consumer med safety website have many patient counseling sheets like you see on the screen that are free to use. You'll see the link at the bottom. Now, please keep in mind, these are not meant to be given in replacement of counseling, but to enhance counseling, because these will have, as you see issues on the left, additional advice on how to prevent issues and misuse of the insulin, not just the clinical stuff on the right-hand slide, but actual other issues with mix-ups and checking your blood sugars and so on and so forth. And we have other examples coming up I'll show you later. So next slide, Jordan. So next we're talk about, we're going to talk about oncologic meds, but we're going to stick for time's sake specifically to methotrexate. So let's move to the next slide here, and you'll see just one case example here. A pediatric patient was prescribed. Oh, hi, Paula. I see your chat. Yeah, Paula, we do have some available in Spanish. I don't know if they all are in Spanish, Paula, but I think a lot of them are. So check the link out, and they're both English and Spanish on that webpage. So you see again, this case, a pediatric patient prescribed a weekly dose of methotrexate, which is 3 tablets twice a day on one day of the week on Thursdays for psoriasis. But the patient's mom didn't understand that. And instead gave this person 3 tablets twice a day for a week. And this person was hospitalized due to methotrexate toxicities. Now, let's go to the next slide, Jordan. And now this is a patient where there's patient confusion. But let's talk about the problems we're seeing in the prescribing and the pharmacy end of this. Now, what you're seeing on this slide comes from what we call our targeted best practices. Now, these are specifically for acute care facilities. And if I'm correct, I think Mike Gaunt will touch this later, we are probably coming out with community pharmacy targeted best practices. So I included this on here. I'm going to bet money it's going to be on the community target best practices as well. So just real quick, a targeted best practice for ISMP are issues that have been repeatedly submitted or reported to ISMP for years and years and years. And essentially we're tired of seeing the same things being reported for a long time. And it's one of those things where it's time we all step up and eliminate some of these dangerous errors. So the errors happening here with methotrexate is when prescribers accidentally prescribe methotrexate once daily instead of once weekly for non-oncologic uses, or pharmacies accidentally enter daily instead of weekly as well. And both times those aren't getting caught. And keep in mind, you saw in the last slide, in the outpatient setting, if this error goes through and someone's taking daily methotrexate, you may not see them for the next refill because they'll be out of tablets and they'll probably be in the hospital by that point in time. Next slide, please. So part of the best practice is, making sure confirming the daily doses versus weekly doses and the indication, but also how about our order entry systems? Do your order entry systems have a way to hard stop you from entering a once daily order for methotrexate? Or do you have a way to clarify? If you get a once daily order for methotrexate, are you clarifying that? Because if it's not for oncology purposes, it's wrong. Think of all the immunosuppressive type uses that methotrexate is used for, like psoriasis as an example. It's going to be once a week, maybe twice a week, but only once a week. So what do you have in your system to stop this from even happening, to eliminate the human error, right? You can educate your staff all day and night, but we still need to have a good hard stop in the system to not let us proceed. Next slide, please. So again, part of the best practice is, again, making sure, at least in the acute care setting, that we are educating patients specifically about this problem. On the right-hand side, again, you'll see another example of another teaching sheet we have from the consumer website specifically for methotrexate to help you with that issue. So let's go to the next slide. And I think we're on the last section for me on opioids. Yep, a couple more slides, and I'll pass it over to Mike. So, background-wise for opioids, obviously with the opioid epidemic that's been taking place, which I'm sure it's still happening, but other things have taken precedence over this right now. But a lot of issues with opioids that starts often at the prescribing level and then perpetuated by the next level in the pharmacy realm. So for example, just inappropriate prescribing of opioids. Multiple, patients with multiple opioids, even say Vicodin and a Percocet as an example, with multiple doses, inappropriate prescribing long-acting opioids, we'll touch on a little bit. When you're dispensing an opioid, do you care about the person's comorbidities? Does someone have sleep apnea that's getting a high-dose opioid? Does that impact you? How about their age? If someone's 80, do you approach the dose different than someone who's 50 years old, as an example of that? So are we really considering, and again, this goes to prescribers and the pharmacists, are we taking into account that patient and their information about them regarding the dosing? And through another study in here, we saw that one study showed that 1 out of 5 patients reported sharing their opioid medications with another person. And of those with leftover opioids, 61% reported keeping them for future use. So we also have that on top of it as well. Next slide, please. And the key thing comes down to this definition of, do we know if a patient's opioid naive or opioid tolerant? And the big deal is there's certain opioids like the morphine, 20 milligram per ml, high dose OxyContin, high dose MS-Contin, fentanyl patches are only indicated for opioid tolerant patients who meet this requirement. So as pharmacists, are we even aware of this? So a patient walks in with a fentanyl patch. Do you have any questions before you fill it? Are they opioid tolerant? What were they on before as an opioid? Do you have other pre-existing conditions? Again, it's different for a hospice patient than other patients as well. So do we know that information? Next slide, Jordan. And so going to the fentanyl patches, yeah, a lot of issues, inappropriate patient selection, they're not opioid naive, improper disposal. We have reports of deaths, people, when children of patients on fentanyl patches at home had put the patches on themselves and they found their kids dead. So what are you teaching patients about how to dispose of patches when they get home, how to destroy them? Patient confusion about proper application. Do they realize that they're supposed to remove a patch and put another patch on? Or do they just keep all the patches on? And yes, patients have been admitted to EDs with multiple patches on them because no one told them to remove one, put the next one on. And also the awareness of patch, which is probably more of an emergency department thing as well. So let's move on for time's sake here and move on to Mike here. So next slide, Jordan. So again, we're having problems with fentanyl patches, which is going to be leading us into another targeted best practice. So Jordan, let's go to the next slide here. We talked about this already. So yeah, in the acute care, this was a newer one we just added, but we are asking in that setting to verify, document the patient's opioid status, naive versus tolerant, and the type of pain they're getting for all extended release and long-acting opioids, right? Again, people have inappropriately gotten these have died from the inappropriate prescribing and dispensing of them. Next slide, Jordan. So we obviously support the appropriate use of them, but also want to prevent the inappropriate use of fentanyl patches. Keeping in mind, we have another example of a guide sheet to the right, patient education sheet on fentanyl as well that you can use for this issue. And let's go to the next slide, Jordan. I think I have 2 more slides to go. So let's talk strategies for a minute, and I'll pass this along. When it comes to strategies, one important thing, it's one thing to maybe have your own higher medication list, right? But having a list doesn't mean anything. Hanging a list on the wall doesn't mean anything. It only means something if there are strategies you're going to put into place in this setting to prevent harm to patients at the end of the day. Right? So some of these are preventing medication errors in the pharmacy, some of these are preventing errors in the patient's home. So it's important that you identify, first you have to understand why the error happens. Why are these errors happening? And then address that with a good strategy. And it's got to be, we say, layer strategies. It's not just educating staff. There's got to be other things like the hard stop we mentioned regarding methotrexate. Maybe there's hard stop counseling for fentanyl patches where a patient can't get their prescription bag until a pharmacist has to talk to them about how to use a fentanyl patch as an example of that. So it's important to communicate the list to your staff of these high alerts, what the big deal is, why is such a concern, along with strategies, but also see if these strategies actually work. So last slide, Jordan. So some specific ones we could use before I pass it along. Should we have prompts to kind of force us to obtain, review, or verify critical patient information? Allergies and reactions, pretty common, but does it have to be forced? Patient weights for enoxaparin orders. We didn't talk about enoxaparin, but you need a patient weight to know if it's a correct dose for enoxaparin. Actual weights, not estimated weights. Lab values, opioid status as examples. Should there be, a second bullet, a trigger that requires mandatory counseling for select high alert medications? So is there a way that you can't ring it up until a pharmacist talks to them? Is there an alert on the bag that no matter what, Anyone who gets methotrexate gets mandatory counseling. Anyone who has a fentanyl patch gets mandatory counseling. And there are other electronic heart stops we mentioned at the point of sale that we just discussed as well. So on that note, I'm going to pass this now and transition over to Mike Cohen. He's going to talk about some vaccine-related issues. Mike?
Thanks very much, Matt. And hi, everybody. Welcome to today's program. I'm going to be talking about vaccination-related medication errors. Jordan, next slide. And you may not be aware, but ISMP operates a vaccination error reporting program, or a vaccine error reporting program. We actually started that back in 2012, along with the California Department of Public Health, who are our partners with this. And they were very interested in getting reports of vaccine adverse event reports that weren't actually reactions, but more on the error side. And like I say, we started that in 2012. We do share these reports with FDA's Center for Biological Evaluation and Research, and also the CDC through the Vaccine Adverse Event Reporting System. But by the way, and we'd love it if you would report vaccination or related incidents that occur in your pharmacy, wherever you practice. However, keep in mind that vaccines that are available under emergency use authorization, they have to be reported. Those reports have to be reported to VAERS, the Vaccine Adverse Event Reporting System, not to ISMP. However, you can report to ISMP in addition to VAERS, and we would love it if you would do that. It gives us the opportunity to write about some incidents that you might not be aware of otherwise. Next slide, Jordan. Very easy to report. You go to our homepage at ismp.org. You can see the area in the circle there. That's pulled down. Next, you'll see one for consumers, one for healthcare practitioners. And then when you hit that, you are asked if you want to report a medication error or a vaccine error. We have a very active medication error reporting program. And also a very active vaccine error reporting program. We also operate a consumer error reporting program. So we hear from consumers as well. And you heard earlier, Mike Gaunt, who'll be speaking after me, is the editor of our community pharmacy newsletter. I'm one of the co-editors of the acute care newsletter. And we have other newsletters as well where we carry this information and make people aware of the reports that we're getting. So it's really essential that you get these publications. You may be able to get it through your chain pharmacy or through the ownership at your pharmacy. Also our website, you'll see the main article each time. That's available for anybody that goes to the website under the newsletter section. And also you can get information about other types of errors that are reported as well. And every once in a while, we'll have something that's just so serious that we put out a national alert. And I'll show you that in a second too. Next slide, please, Jordan. And we just really want the narrative information, although the vaccination error reporting program, it really asks you for a few other bits of information. We don't have a lot of fields. It's a very simple action on your part to fill out a report. We have never identified an individual or an organization or their location in all the years that we've been doing this. And our medication error reporting program started in really back in the 1970s as a journal column. And you may see it now even in publications like Pharmacy Times, for example, or if you're an APHA member, Pharmacy Today. We have many other publications as well that our professional staff does on a regular basis. Next slide, Jordan. So that's just what, and by the way, it doesn't look exactly like that now, but I had to slide, so I use that. It's a little bit different, but basically it's the same information that we're asking for. These are just some of the details. I don't have to go through this right now. You can probably guess what they are. Next slide. And also there are pull down lists. So if we ask about product related contributing factors, it doesn't have something to do with age. We are getting a lot of age related events. In fact, we are predicting, as you probably know, the pediatric vaccine is being discussed as we speak here today by the FDA's Vaccine Advisory Committee. We expect that that's going to be approved soon. And we are very concerned about mix-ups between the adult and pediatric vaccine. And I'll go into that in just a second. But you can see some of the things that we would ask for under various categories, not just these three, but others as well. And you can just select the appropriate answer. And if we need to, we can get in touch with you for follow-up information. We love photographs too. So if you're telling us about a lookalike vaccine or medication, or for that matter, if you could take a photo, that would be greatly appreciated. We use those in the publications. Screenshots, if you've been involved with a screen selection or just about anything that can be visualized, it would be great. It's all about helping one another. We're pharmacists and nurses at ISMP. We have a physician medical director, but we're just here to turn that information around to you, our readers, so that it can benefit you and you can be aware of some of the problems that are out there that people are running into. We work very closely with FDA to get a lot of these changes in product labeling. It's really affected thousands of products over the years that we've been doing this. Just one change alone could be over 1,000 products where the label has to change. But we also do individual product changes. And sometimes we've had products taken off the market because of serious medication errors or drastic changes in the packaging. And it's all because of your willingness to have us act as your liaison with the FDA, or in practice-related issues with one of the standards organizations, from USP to Joint Commission to URAC if you're a specialty pharmacy, or any of the other accreditors for specialty pharmacies as well. Next slide. We try to predict what might happen based on our reports that we have. For example, back in November last year, we knew that we're in flu season, and we knew that they were actively working on the COVID vaccines, which were later released in December. So that article on the left there, we literally looked over all the flu reports that we were getting and tried to predict what kinds of things we might run into with the COVID vaccines. And I'll tell you what, that was pretty accurate. We picked up a lot of the errors and predicted that they would happen. And our readers got a feel for what they need to be doing to prevent these types of errors. So I think that's really important to get this information. That would be on the website, as a matter of fact, but it'd be also in our newsletter. Our community newsletters every month, and the acute cares every 2 weeks. Goes to basically every hospital if you're a hospital pharmacist. Learning from errors with the new COVID vaccines, that was back in January. We only had a month's worth of data, and yet we were seeing very, very similar errors in community pharmacy and in clinics around the country. Health departments were reporting them to us. And we got a whole article out on what was going on with these errors. All these kinds of crazy things, like people injected with air. In fact, I'll go into that in a couple of minutes. Or the vial of Pfizer vaccine being injected with 1.8 milliliters of air, or sterile water for injection. And these are all preventable errors if you know what to do. And that's what we were trying to get out there with that information in advance. So please do follow it. Next slide, Jordan. So this is just what we were looking at. I don't need to go over this slide. I basically told you about it. It was on the previous slide on the left, but these are just some of the things that we included in the newsletter and gave some recommendations for preventing these lookalike vaccine names and labeling and packaging issues. One of the problems we've had is mix-ups in storage. And so we like to see the product segregated. And some places are using colored bins, like red bins for the Moderna vaccine, blue bins for the Pfizer vaccine. We just heard about that, and that's not a bad idea. The only issue is some pharmacists work in more than one pharmacy, and it might be blue for the Moderna in another pharmacy, so don't get too used to it. But anyway, these are the kinds of things you have to keep in mind. A lot of communication barriers. We definitely want you to have an independent double check. So if you're a pharmacist and making a vaccine up, please get your pharmacy tech if you're the only one in the pharmacy. Or your pharmacy tech mixing it, you should be checking their work before it goes out. Look at the vial, look at the label. We would love it if you would label these products. Too many of you are not labeling out there. And that is a big deal because we want the patients to be involved with our prevention. if they could be shown the product label rather than just an empty syringe, that would be big. And there's no reason you couldn't pre-print these labels and then put them on the syringes, whoever's making it, and then distributing it to another pharmacist sometimes who's giving it. And you don't know what's in that syringe for sure. Anyway, we'll get into that in just a second. Next slide, please, Jordan. We did just publish a couple of weeks ago on October 7th, all the mix-ups we were getting between the flu vaccine and the COVID vaccines now that it's flu season again. And you can just imagine what, this could absolutely be predictable. We did predict it. And, it's absolutely a mental slip, or unlabeled syringes, or keeping both of these syringes in the same area where you're working. Some are getting the flu vaccine, some are getting the COVID vaccine, and you're giving it to the wrong patient. We got up to 16 when we published this. I think we only have 1 or 2 more because we also did a national alert. Next slide, please, Jordan. So this is the national alert we did just a couple of weeks ago, or a week ago or so, on mix-ups between flu vaccine and COVID vaccine. And we sent this to 25 healthcare organizations and asked them to distribute it to their constituents, which is you. So I know if you're a California pharmacist, and in some other states, California Board of Pharmacy sent this to all licensees. We were so happy that they did that, because we gave you a lot of recommendations, not just prevention, not just what was going on, but also prevention measures here to prevent this mix-up, whether it was a mental slip, a vial mix-up and where it was stored, syringes that went unlabeled, not involving the patient, all those kinds of things were in this alert as well. It was based on the article that we did the week before. Next slide. That NAN alert, the National Alert Network, is very important for you to be aware of. We distribute these through the National Coordinating Council on Medication Error Reporting and Prevention, where both Mike and Matt are very much involved with NCC NCMERP, it's called, NCC MERP. So what kinds of problems did we have in that newsletter article? Obviously, people coming in for flu vaccine and people coming in for COVID vaccine at the same time, and increased demand. Right now we're in a situation where there's a vaccine mandate, sometimes by individual companies, sometimes by states or other organizations. And now we have any company that deals with a governmental organization, federal employees have to be vaccinated. And that unfortunately is leading to a real workload for our pharmacists who are doing other things in community pharmacy, filling prescriptions. My own pharmacist, I went in and got a flu vaccine a few weeks back. She told me she had given 50 shots already that shift. And that was like, a 12-hour or 13-hour shift. Maybe that's not even a lot for you, but it sure seemed like a lot to me. And she did not have another pharmacist there. They had the window. They had all the patients, standing at the receipt of prescription. And, I don't know how she got it all straight, but fortunately I got the right vaccine. Anyway, syringes near one another, which I already mentioned, unlabeled syringes. I think we really do ourselves a disservice in pharmacy by bringing the vaccination syringe. Maybe it's made by someone else and transported to wherever you're giving the vaccine to the patient, in a little room, wherever it is, and it doesn't have a label on it. I'm telling you, there's ways to get labels on these vaccines, and even scan a barcode so that the barcode on the vial is scanned, and you have a barcode that could be printed, like a 2D barcode, just like on the vaccine container, and even scan that to make sure that you have the right syringe. There are ways to work on that. Next slide, please, Jordan. Distractions, I just talked about, people coming up, driving up to the window, and I don't have to tell you, you're a community pharmacist. You know what you go through on in a busy pharmacy every day that you work. And our staffing has been a problem. It's always been a problem, but now it's even gotten worse. I don't know if you've noticed that or not, but we certainly get those complaints at ISMP through our reporting program and our discussions that we have with pharmacists. So we feel for you, our colleagues, we really do. And we know that you're doing your best out there. And I'll tell you what, there's so much complexity now. And it's getting even worse with the booster shots. We have different doses, for example, in the Moderna that are coming. We have pediatric doses. And by the way, before I forget to tell you, a lot of you have been writing to us and telling us that you're very concerned about the Pfizer 30 microgram per 0.3 ml, and the dose is only 10 microgram in kids. It is not 10 microgram per 0.1 ml though. It is 0.2 ml. So it's a little bit less concentrated for more volume. And that's important to know, but I really, really worry. Mental slips, syringe mix-ups, kids and parents coming in at the same time for their shots. It is absolutely predictable. So you need to start working right now in your pharmacy, talking to other pharmacists, talking to your ownership, talking to your supervisors, and coming up with ways to prevent these errors. We're giving them to you. We'll be publishing them in our newsletter next week. So look for them being published next Wednesday night. Next slide. That's not for the community newsletter. I don't know. We'll have to see how we get that communicated. It'll probably be on our website. I think it's important enough to get it to everyone. More recommendations, staffing support. We even had volunteers in some places. I happen to be certified to give vaccinations. I intended to be licensed, but I didn't get around to the CPR course, so I'm not available. But there are many other pharmacists that will do this. Maybe there's a way to get them involved wherever you practice. I don't know. Certainly in clinics, we saw a lot of that. And you want properly trained individuals. We have a big problem with SERVA, shoulder injury related to vaccine administration. And a lot of that was due to people that might have had it within their scope of practice, like a podiatrist or a dentist or a dermatologist, maybe, that don't normally give IM injections, giving vaccines and then hitting the acromion or a bursa or a tendon. And unfortunately, people have severe injuries sometimes, even sometimes needing surgery. So you need properly trained individuals. And the APH course, if you haven't had it in school, is definitely one that you should have taken. Label the syringes, separate the vaccines in both storage, and never use them around one another on a table if you're involved in multiple vaccines for multiple patients at the same time. Always one patient at a time. Identify the patient and be sure to ask the patient which vaccine they requested. And even that is not 100% preventive if you have the wrong vaccine in the syringe and you're not checking. And you don't have the vial there because it's a 10-dose vial or a 14-dose vial or whatever the number is. You don't generally have the vial where you're actually administering it unless you're a one-man operation and you happen to take it with you. So keep all that in mind. Next slide. Involve the patient and the parent. Document the lot number and expiration date. Sometimes that's a clue. You're giving the wrong vaccine. You want to document it. I love barcode scanning as a preventive measure. That's why that 2D barcode is on the vaccine bottle. Not a linear barcode. You have the expiration date, you have the lot number, you have the drug identification. Provide the intended vaccine. If a mix-up occurs, tell the patient what happened. We're a little bit better off now than we were a few weeks ago. If you give Moderna instead of Pfizer, that's not the problem that it was in the past. But and you can explain that to the patient. You can also explain it if you give the flu vaccine instead of the COVID vaccine, because many patients do really need both, and it's perfectly okay to give both at the same time. As you know, CDC has approved that. Report vaccination errors, as I said, to VAERS, but also to ISMP. That's how we get the information. And by the way, next slide, please. FDA does make available, CDC does make available medication or vaccination or information. I'll show you that in a second. This is a real concern. And again, I need you to be working on how to prevent this from happening, because little kids getting the adult concentration are going to get a really bad local reaction. That has already happened with the flu vaccine mix up, when a 4-year-old or a 5-year-old, some of these made the national media, by the way, get the wrong thing injected. Next slide. And by the way, you will see, you probably saw it on CNN or one of the news programs, that they are making the pediatric vaccine for COVID in a different color cap. Forget about it. The caps pop off. That cap doesn't go with you and the vial doesn't go with you. You're going to be using vials without the cap color. They may look different. We have mix-ups reported of hepatitis A vaccine, pediatric and adult, pediatric on the left, adult on the right, hepatitis B vaccine, Tdap, DTaP. I could just go on and on where there's an age-related difference in the type of vaccine that you give. So do not count on the appearance of these vials. You have more work to do. And I hope that, I'm kind of bothered because I've heard that already from FDA. And, that is not a prevention measure. It's helpful and it may prevent some errors, but it's certainly not going to prevent all of them, as witnessed by these vaccine errors that we get once the cap color is popped off. Next slide. And the same thing with the two different forms, adult and 3 years and older for influenza vaccine. Next slide. And many, many others. That's an older version. We have I'm going to give you just a little bit more and then I'm going to turn it over to Mike. I did want to talk about these issues with the COVID-19 vaccine errors because we're still giving them and it's waning a little bit. And that's, more and more people are being vaccinated, but we're starting to see more and more booster shots being given as well. First of all, the dilution errors leading to underdose or overdose. We have many reports of no diluent being used for the Pfizer. By the way, it only involves the Pfizer COVID vaccine. That's the diluted one. But now we have the pediatric too, by the way. So that has to be diluted. So this could happen with a pediatric as well. Problem is, some people will go right into the concentrated vial. We've had entire vials of 0.5 ml given, the entire vial contents of the concentrated being given before dilution. We've had over dilution done. So all kinds of things. We've had sterile water for injection used. So there's a mixing error with these two component vaccines and the wrong diluent instead of sodium chloride. That dose should be repeated, by the way. CDC is saying it should be repeated. And we've had a lot of those reports. Air injected into the vial, 1.8 ml of air. Well, a lot of you will, especially when you're making a lot of vaccines, you'll pull 1.8 of that. You'll open the syringes from the paper, put them on a table, draw up 1.8 ml because that's what you're going to push into the vial. And then that gets mixed up with the diluent after you draw up the 1.8 ml. So some syringes have air, some syringes have diluent. And guess what? Air gets injected into the concentrate, then they draw up the concentrate without dilution. Or even worse, we've seen it done with injecting patients as well. You may have seen that one of the pharmacies made the national media back a few months back. And we just got another report over the weekend, air injected into patients. And it's again, where you're not using it, where you draw up 0.5 ml, or whatever the amount of diluent, not 0.5, whatever the amount you're giving to the patient, injecting in the patient, you're drawing that up in air to push into the vaccine vial that's already been diluted. And then you draw up the diluent, the vaccine liquid. But unfortunately, some of these vaccine doses are being given as air only because they get mixed up with the actual vaccine in syringes, the same volume. So air gets injected into the patient. So that's been bad news. Wrong vaccine, and if you identify that, you have to call the patient back, obviously. Wrong vaccine given for dose number 2. Administration of the wrong age group. We had a lot of kids before the vaccine was approved from 12 to 15. And I'm sure we're going to see the same thing with younger kids. Sometimes we had doctors writing prescriptions for 12-year-olds and people got hoodwinked into giving it to them. That was not approved. Waste of vaccine, that doesn't seem to be the same issue as it was early on. But if you can get another dose of vaccine out, you're still within the expiration date or the beyond use date, that's a plus. Errors in scheduling the second dose, the timing, get a lot of them. People don't always tell the truth or they're confused. You need to be looking at the immunization information system where you have one, and you all have one. It's run by your state or even a city or some other organization. And hopefully we're using this pre and post injection, so we keep a good record of what the patients had. And if you check that, you would be able to find out what they had for their first dose, and you don't give the wrong second dose. Lookalike vials, we had a monoclonal antibody mix-up that involved like 30 or 40 patients, where the Moderna vaccine just looked exactly like the casirivimab vial from Regeneron, which was one of the monoclonal antibodies with Indevimab. And also, again, the shoulder injury related to vacciners. Next slide. And just there are articles on this shoulder injury. We publish them in our nurse advisor that's available on our website. Next slide. And verify the competency of preparers, which I said. Dispense pharmacy prepared and labeled syringes whenever possible. Find a way to do that, please. One person prepares, another one administers. You need an independent double check. If one person is preparing, then another pharmacist should check, or a technician should check. For mass vaccinations, utilize a standard organized process with independent double checks. Maximize doses withdrawn from vials. Identify, differentiate monoclonals. Separate vaccines in storage. Plan for leftover vaccine. That still goes on, where you have leftover vaccine and no one to give it to. If you have some backup people that want the vaccine and they're willing to be called, why not keep a list going? Be prepared for allergic reactions. Report vaccine errors and use the immunization information system. Next slide. I want to get to that. Well, there goes the unlabeled syringe on the right at the top. It just goes against me to not have a label on a syringe. Next slide. USP has great information on the USP website about vaccination. It's meant for you guys to read. Next slide. This is the error information from CDC on their website. Next slide, Jordan, and then one right after that. This is also one from CDC. Next slide. You know, could you keep advancing them to get to the epinephrine? And I want to end with that. Expiration date standard is coming. USP just published it. Next slide. There's going to be one way to expire, write an expiration date. That's really good news. Go back. That's what I wanted. Look at the adrenaline in the middle. Guess what happens? People get injected with adrenaline, 0.5 ml instead of the vaccine. That's because the vaccine is around the Pfizer BioNTech, and it looks very, very similar. So, you know, it accidentally gets picked up and injected into patients instead of withdrawing from the vaccine vial. So don't keep the adrenaline anywhere near there if it's packaged like that from Par Pharmaceuticals. By the way, it no longer has a ratio expression 1 to 1,000. That's an old label, but it's the only one I could find. I'm going to stop there and hand it over to Mike. Mike, go on.
All right, thanks, Mike. Jordan, yep, great, thank you. Good afternoon, everyone. Real quickly, I just wanted to highlight a few existing and upcoming resources that will be available for you all to use. One of them Matt commented on is that we will be developing targets for the community ambulatory care setting, much like we have done for the hospital setting. And I would imagine similar to hospital, we'll have something on methotrexate since we continue to get those daily versus weekly mix-ups. The other thing that's obviously been talked about in the chat, as well as Matt mentioning, is our consumer medication safety leaflets. Those are available on our consumer website, and our consumer website is actually getting updated at the end of this year. So look for more information. It's a great resource for pharmacists to actually access and then refer patients for more medication error prevention strategies. And then finally, as you can see here on the slide, we are releasing an updated community ambulatory pharmacy medication safety self-assessment, and we'll be launching a new self-assessment for specialty pharmacies. That'll be happening in the next month or so. If you're familiar with our previous self-assessments, these will be similar, structured similar according to the 10 key elements, and really allow you to identify gaps in your current safety practices within your setting. If you want to go to the next slide, Jordan. The one exciting thing we have with the new self-assessments in conjunction with our affiliate ECRI, we're also developing these as an online assessment, different than what we've done in the past. This will allow you to actually survey your individual staff members to get feedback, and will generate a dashboard similar to what you see here. Eventually, you'd actually be able to have some comparative data to other pharmacies or specialty pharmacies, depending on what your setting is. This system is also set up to be anonymous from a practitioner standpoint, so you can really get that feedback from your individual staff members, and they can be assured that there is an anonymity built into the data collection tool. And like I said, the PDF for the community version, as well as these electronic versions for both community and specialty pharmacies, will be launching later this year. And I think that is where I will stop.
Jordan, next slide, please. I just want to mention, we have some workshops coming up so that you're aware of them. We do these on a regular basis. It's 2 days. It's 12.5 CE credits for nurses and pharmacists. And pharmacists, nurses, physicians, risk managers, academicians are all invited to participate. The next one is on December 2nd and 3rd. It's virtual, I believe, so you don't have to travel anywhere, and reasonable registration fee. And next slide, please, Jordan. I did want to mention and thank Novartis, especially their name creation and regulatory strategies department, for sponsoring this webinar so that no registration fee was necessary. They have just been phenomenal, Novartis. They have a fellowship program for pharmacists, by the way, at Novartis. They have medication safety people at Novartis, and that's who is sponsoring this, along with the department head and name creation and regulatory strategy. So we greatly appreciate their sponsorship of this program. And do we have a couple of minutes that we can spend, Jordan, for questions?
Absolutely.
Okay, why don't we do that? I haven't looked at the chat or the question and answer section. Anybody looking at that?
Yeah, Mike, I'm right here actually. There is one question that came in the Q&A box from Iman asking, can we report practices that can possibly result in error? And Iman, I would say, I would absolutely encourage people to report those close calls, those unsafe conditions, those packages, those products that can concern you, but also unsafe processes. So Iman, yeah, we can, this, even though it's called an error reporting program, really it's all the above, including hazardous conditions. So definitely consider reporting either to our medication error reporting program and also our vaccine reporting program. Keeping in mind, especially with the medication error reporting program, we're not just looking for error reports, we're looking for the results of your investigation. Why do you think that event happened? What type of strategies you're going to use? Because we learn from people who submit reports and information to ISMP. So Iman, thank you for that question.
Totally agree with Matt. They're threats. We learn from threats before anybody ever gets hurt. When you guys tell us that there's a lookalike problem, that could hurt somebody, we want to know about that so we can get the word out and you can do something about it if you read our material. One of the biggest problems we have is there's no oversight. So you're on your own in many cases, unless you have a supervisor, an owner, the chain headquarters that's really serious about preventing patient harm. And that's number one. It should be in their mission statement, as a matter of fact. That, above all, is why we're pharmacists. We want to make sure that drug therapy is safe for patients. So when we get these threats to a medication error, we publicize them as best we can so that you know about it. So totally agree with Matt.
Yeah, Mike, we got this other question. Pam put it in a chat box, and she's saying, from her experience has been that the vast majority of errors are due to failure to follow standard operating procedures. What are you seeing? And Pam, I'm going to answer that because failure to follow a standard operating procedure or failure to follow a policy procedure is not a root cause of an error, right? So while that may be true that people aren't quote unquote following their policies, that's not telling us why they can't follow them or why they are not following them. So I would not agree with that because inevitably that's not telling us anything anyway, unless we know what were the conditions, the working circumstances that pharmacist or tech felt like they couldn't follow it. Maybe they didn't even know about it. Or that in some organizations, we're seeing in some ways a tacit acceptance of people not following them to get the job done quickly. And especially in the outpatient pharmacy environment, I'm sure there's a lot of pressure to fill things as well.
Very good. Matt, I see one here. It says, where did it go? Oh, my experience has been the vast majority of errors are due to failure to follow standard operating procedures. Well, I think that's important for sure. I don't know if it's the vast amount that we get reported to us. I will tell you that, there is human error, that's for sure. The lookalike problem, for example, or poor labeling by the pharmaceutical manufacturer that trips you up. That's why we have barcoding, to make sure that you're getting the right drug to the right patient. But yes, and the standard operating procedure isn't followed. You don't do the barcode scanning before you actually dispense the drug or prepare the prescription. So those things are absolutely true. But there are a lot of things out there that are related to human error that would trip me, I'm sure. I do it all the time when I go to the supermarket, for example, and pick up the wrong product. So anyway, and then there's what we call at-risk behavior. There's groups that have tried to bring some science to this. It's called just culture. We subscribe to that. Human error, at-risk behavior, where people routinely are rewarded for taking shortcuts. People standing in line, they'd love you to get that prescription back to them as soon as possible, rather than call a doctor and do all that you're supposed to make sure that it's safe to give that particular prescription under that circumstance. And unfortunately, people don't always do that in the pharmacy, and they do sometimes get the prescription out, using a shortcut of some type, not calling the doctor in that case. So that's at-risk behavior. That is risky, and if we're following standard operating procedure and there's a process for contacting the doctor, absolutely. And then there's reckless behavior, where you have looked at these at-risk behaviors, you've made it clear to the staff what the proper procedure is. You've made changes in the system to make things as preventative as possible, and yet people still will take the same shortcuts they were taking before, and then somebody gets tripped up. That might be some cause for disciplinary action. Reckless behavior certainly is. So anyway, those are the kinds of things we think about in that regard. What else do we have here? Anybody else see anything? Somebody said, do you need to get an air bubble out of the syringe? Well, yeah, I mean, if it's tiny, sometimes it's very difficult to flick it out, but obviously anything of any consequence you would want to flick out, because you're trying to measure a dose accurately. Obviously, we're all aware now of the dead space in the needle hub and the syringe tip, and we use syringes and needles with almost no dead space wherever possible. Like an insulin syringe is epoxied. It has almost zero dead space, so that most of the vaccine gets injected. This is going to be particularly important for children, obviously. Okay, I guess that's it, unless you see anything else, Matt.
No, I think we're good, Mike. I think since we're a little over, we'll go ahead and wrap this webinar up. And I want to thank again, we had a lot of attendees today. So thank you for hanging in and listening to our webinar today. Thank you again for supporting us, and hopefully we'll talk to you soon. And this formally concludes our webinar. Thank you.